session, Dr. Balakrishnan, who needs no introduction here, and Dr. Ullas, of course, who's our own. So as I pass on the mic to both of them to start the session, I would just request Dheeraj to kindly put everybody on mute. Dheeraj, please put everybody on the mute.
Okay. Okay. Yes, ma'am.
Yeah, Dheeraj, no, everybody. Okay, so I request the moderators and the speakers to please unmute themselves. And over to you, Dr. Bala and Dr. Ullas.
All right. So, Vanita, again, thanks very much. You have been successfully organizing these web series. Well, from next week onwards, we have decided that, the time is going to be changing and only once a week. But so far, I think almost like now 15 sessions we have had, Vanita.
Yes, of course.
And each one of those sessions has been so very educational.
Thank you. Good.
Thank you very much, and it has been all stored. And today, as Vanita was telling, it's a very, very important day for two reasons. One, we could rope in the master or the pioneer of heart transplant or LVAD program in the country, Balakrishnan, and I have the special privilege of interacting with him. He is from my own city, and his institute is just a stone's throw from here. I had been interacting with him and his colleagues, sometimes with respect to arrhythmia and the devices with LVAD, etc. And it's such a huge pleasure for the Indian Heart Rhythm Society to have Bala to be with us, to be moderating one of the important issues, not necessarily a familiar terrain, a very, very unfamiliar terrain for most of us, and that is something to do with the left ventricular assist devices. There are many reasons, but most important reason is the economic and the social reasons here why we do not see many of the LVAD patients. But the way things are improving, the economy is improving, I think we are going to have our patients to receive LVAD. And when we are talking about the devices and arrhythmia, looks like Indian population of LVAD patients, I think they will be having more frequently these devices because these are the patients who could afford first at least a device. For example, a pacemaker or a CRT or a defibrillator. This is the people now when they start deteriorating further on, these are the people who would be now affording LVAD. So now this particular topic of the devices and arrhythmia management in those patients with LVAD, I think it is quite relevant, even though we don't deal with many of the LVAD patients. And to address this particular issue, I'm privileged and I'm glad to introduce Rakesh Gopinathnair, who I think most of the attendees today know that he had been the first author of American Heart Association scientific statement addressing this particular topic. So the statement was, I think, was released a year or so back. So he's the first author of the AHA scientific statement addressing this. Rakesh had been having a fantastic EP career. He did his MBBS from Government Medical College, Trivandrum, Kerala. He currently is the director of EP program at Kansas City Heart Rhythm Institute. He had been holding some important scientific and communication program for American Heart Association and Indian Heart Rhythm Society. So it's privileged, Dr. Rakesh, to have you. And my co-moderator, Dr. Bala, might speak a few words before you take off. And we welcome, IHRS welcomes the Rakesh, and then we are very privileged to hear these LVAD issues from you. Bala, I request you to say a few words before Rakesh takes over.
Dr. Bala, you have to unmute your mic, please. Dr. Bala, sir.
Bala, can you unmute and talk to us, please?
I think Dr. Rakesh, you can unmute your mic, please.
Rakesh can start in case Bala has some issues there.
Yeah.
Okay, can you hear me now?
Oh,
Yes, Dr.
Bala, yes.
All
yes.
right, okay,
Yeah.
fine. So it's a pleasure for me to be part of this meeting, and the amount of work in this area is progressively increasing every year. Now we are on an average implanting I think 2 to 3 VADs a month, and with increasing awareness, this number is bound to increase. But the topic for today is very pertinent because for a long time we used to have the opinion that the moment you put an LVAD in, you no longer have to worry about arrhythmias because they disappear on their own magically. That's not necessarily true. Of course, today's speaker will highlight a lot more about this. And this is a very important issue. And at the end of it, perhaps, if we have time, I shall briefly share with you our own experience in dealing with bad arrhythmias and VADs. And maybe we can learn a lot from the experience of Dr. Rakesh. Over to you.
Thank you. Thank you, Dr. Bala, Dr. Ulas, and Dr. Vanitha and IHRS for giving me this opportunity. So this has been a sort of a research interest for me for several years, and so I kind of have had the pleasure and privilege to work with a lot of excellent VAD surgeons and researchers in the US and also with heart failure specialists. So so that interface between advanced heart failure and EP has been a big interest. So we over the years we have our group and others has done some work in this arena, so which I will share. So probably about 30 minutes, I'll speak about some of the pertinent issues, share a couple of cases, and then we can open it up for discussion, hear everybody's perspective. And this is an evolving field, as Dr. Bala mentioned. This is a growing population. According to the Intermax registry, there is, almost, it is getting to, I believe, 18,000 VADs being implanted, and it's becoming more and more given the new types of VADs that are coming up, the intrapericardial, smaller LVADs. They're more durable, less thrombogenic, and people are living longer. So we are bound to see this, bionic men and women in going forward. So I think, so with that, I'll delve into this. I hope you can see my screen. And
yes, we can see you.
Okay, perfect.
Yes.
These are my disclosures. Okay. So we'll start. This is how I want to organize my talk. We'll talk a little bit about atrial and ventricular arrhythmias in VAD patients, mechanisms, incidence, prevalence, and significance. And want to spend a little bit of time talking about the role of ICDs and CRT in LVAD patients and how best to program these devices in a VAD patient compared to the traditional heart failure patient. Touch upon a little bit about medical management of atrial and ventricular arrhythmias, and I'll show you an ablation case and how to that some people may need to be ablated to improve their clinical profile, including right ventricular function. And we'll talk about some knowledge gaps and wrap it up. So this is not an uncommon question that comes about in LVAD patients. So it's an example. A 48-year-old female, non-ischemic cardiomyopathy, had decompensated heart failure, extremely low LV ejection fraction, EF dimensions of 6.8 centimeters. Underlying rhythm is sinus 85, left bundle at 160. She receives a continuous flow LVAD. By the way, all the LVADs now have been continuous flow. The pulsatile flow VAD days are over. And for advanced heart failure, 6 months after the initial diagnosis, she is implanted as a bridge to transplant. No ventricular arrhythmias or syncope prior to VAD implant. So the heart failure team wants to know if this patient needs an ICD or CRTD following VAD implant, and if so, how we would program it. So this is, we'll get to discuss this case a little down the road, so we'll start with that. So just a quick primer, Dr. Bala could say much more about this. This was one of the original LVADs that was the so-called the original HeartMate VAD, the pulsatile VADs, and these are no longer being used. I want to say from 2007, 2008 onwards, we are using our continuous flow VADs. So this is sorry. Trying to move this. I think I'm probably missing one, but that's okay. So the HeartMate 2 was the first so-called continuous flow LVAD. This is not the picture. I had one. I don't know how I cannot pull it up for. Oh yeah, there you go. So this is the HeartMate 2, which is the first continuous flow LVAD, and essentially every VAD has an inflow cannula that goes into the LV and then has an impeller, and then it has a graft that gets attached to the ascending aorta for flow. And the right ventricle is unsupported, and it's an important factor. In fact, it's the second most common cause of death in these patients. And more recently, we have intrapericardial LVADs, which is much smaller, as you can see, with a shorter cannula and same. The advantages being, smaller and more efficient. And then this, the newest kid in the block is HeartMate 3, which is a magnetically levitated components inside it that actually can reduce shear stress and has been shown to have less VAD thrombosis compared to the others. So those are, and the HeartMate 3 has a little bit of different, it's a little pertinence in the EP side in terms of the how it generates its RPMs and how it can impact ECGs and some of the mapping systems when you do some cases with EP cases. We'll get into that. So, atrial arrhythmias are actually very common in LVAD. Several studies show somewhere between 20 to 50%, and about 20 to 30% develop de novo AT or atrial fibrillation. And pre-LVAD atrial arrhythmias is associated with post-LVAD atrial arrhythmias as well. And available studies, again, one has to, the disclaimer here is that there is not a whole lot of randomized control studies in this field, and so a lot of them are observational. So one has to take it with a little grain of salt in terms of that. And available data shows that atrial arrhythmias have not been shown to be associated with mortality, stroke, or bleeding. And all these patients are on warfarin anyway. And sustained atrial arrhythmias, however, can result in right heart failure. And this has been, our group has also shown that atrial flutter can cause a right heart failure, and that can be a challenge. And so atrial arrhythmias can be significant, but it may not necessarily mean that it is associated with mortality. What about ventricular arrhythmias? Again, very common, 20 to 50%, and up to 20% represents de novo sustained monomorphic VT that happens after the VAD implant. There is a higher incidence during the immediate postoperative period and the first month following LVAD implant. And so in the initial, a few years ago, it was widely thought that most of the VTs arising from after LVAD implant is due to suction issues from the inflow cannula, sucking up against the septum. But over time, we have learned that only constitutes a small portion of the VTs, and that usually happens in the initial phases after the VAD implant, and then it's typically not a problem over time during long-term follow-up. Most of the VTs happen after VAD result from underlying myocardial substrate that these patients have, either non-ischemic or ischemic substrates. They are all like in our advanced heart failure patients, CAR-mediated VT. And appropriate ICD therapies have been reported in about, again, 20 to 50% of patients post-LVAD. And we clearly know now that if you have VT before VAD, there is a much higher chance that you're going to have VT after VAD. So, there can be some salutary effects of the VAD from, mechanical decompression of the LV and reducing, wall stress and so on and so forth. But overall, we are not doing much to the substrate, and so VT can happen if you had VT before. The one other thing about ICD therapies are the challenge here in that the LV is fully supported, and these people can tolerate VT and VF for up to several days without any problem. So almost all the shocks that happen in these patients happen when they are awake. There's hardly ever any syncope or anything like this. So there is a lot of the high shock burden. Not only that, they are mostly awake when they get shocked. So that's a huge problem from a psychological standpoint, and also impact on stunning and the other issues. So that's the challenge in these patients. So this is an example that is not uncommonly seen in LVAD patients. You can easily get 12 EDCGs of VF in these people. And so this is a patient who walked in 3 days after this. The ICD had actually shocked a bunch of times and actually exhausted therapies. And this patient only felt, fatigued and poorly. It showed up in the ED. And so I even consented him for his own cardioversion sedation with this. So it goes to show that how well the VAD supported LV tolerates, even VF, and they don't show up until their RV starts to fail. So what are the data on ventricular arrhythmias? So the question then becomes, how good is ICDs? Do they cause survival benefit, or is it just a waste of battery, or is it just more overkill? So I think I'm missing. Okay, there we go. See, the initial data on these comes from a multitude of multiple observational studies. We know that pre-LVAD ventricular arrhythmias predisposes to post-LVAD VT, but the VT per se has not been shown to be associated with survival. Observational studies show that the association between early ventricular arrhythmias, meaning that if you have a lot of VT in the early postoperative period, that can actually be, there is some association with mortality. But after that period, after a 1 month period, it's unclear whether VT is associated with survival. And the INTERMAX registry is a large registry that actually tracks all the LVAD patients, and they have a lot of data collected over time, and the analysis from that registry shows no association between VT and survival. So the INTERMAX classification assesses the severity of heart failure patients who end up getting VADs, basically. So then the next, when you look at that, this is a forest plot of the bunch of studies that looked at this, and we know, if you can see that everything is kind of clustered around the midline. So it's just not associated with survival, at least based on available data. But VT, as I said, is very well tolerated. It can cause RV dysfunction and right heart failure, and that is the biggest concern here in this case. If it persists for a while, it can cause right heart failure, which can result in poor LV filling and suboptimal VAD function. And VT, as I said, along with ICD shocks, can have poor quality of life, and it's a very common reason for hospitalization in these VAD patients who have a multitude of other issues in that regard. In terms of mortality from LVAD, I mean, Dr. Bala knows it better than me. The number one cause of, at least in the United States, is sepsis, and second most common cause is right heart failure, and then the third is bleeding, and especially intracerebral bleeds or strokes. Those are the top three in that regard. Arrhythmic death is not a big factor in LVAD patients in general. So what about, so this is a vast majority, I would say, even in the way more than 90% in the US have existing ICDs when they get their VAD. In terms of, in the old days, there has been issues with interference between LVADs and ICDs. So especially was a case with the older generation of St. Jude ICDs. They use the same frequency for communicating with the programmer that the HeartMate 2 used. And so after the HeartMate 2 was placed, the VAD, you could not interrogate the device at all. So you essentially had to replace the generator. But that is no longer the case. With continuous flow LVADs, the ICDs can coexist. They have no major issues. They use a different frequency nowadays, 64 hertz compared to the VAD was about 8, I think is what they use, kilohertz. And so they have no issues. Then the practice has been very varying when I initially started working on this, and because people were doing different things. Some people left it alone. Some people continued CRT with same programming. Others turned it off. So there was no clarity on this. So that's kind of how some of the data came about. Again, there's not a whole lot of randomized data on this. Again, a lot of this is based on observational studies. So the initial data came from a paper from Cleveland Clinic in 2010. They looked at about 478 VADs over a long period of time, and only about 20% had ICDs. And they found that in a propensity match study, ICDs were associated with a lower all-cause mortality in LVAD patients. The only issue with that, they included both pulsatile and continuous flow VADs, and it is retrospective, and it was a very heterogeneous group. So it was challenging to figure out which group benefited the most. Further studies was done. This is a study from Columbia University that looked at about 94 patients, and about 77 of them had ICDs, and 47% had ventricular arrhythmias prior to VAD implant. And they clearly showed that only predictor for post-LVAD VT was pre-LVAD VT, and that they also showed that people without pre-VAD VT were at a lower risk and may not need ICD therapy, and they did okay without it. Again, a small number of patients and short follow-up. And the one other issue was that it was challenging to identify ventricular arrhythmias in the non-ICD arm, whether or not they are having it or not. So those are some of the issues. So in general, the take-home point here is that if you have VT before VAD, you're going to have more VT after VAD. So it's a that's sort of theme that's been emerging, and most of the VT after VAD is due to underlying substrate. There are a couple of meta-analyses in this arena. This one that was published in 2016 looked at 937 LVAD patients, which was a bunch of published papers. What they found that if you combine pulsatile LVADs and continuous LVADs together, there is a mortality benefit for ICDs in VADs. But if you only take continuous flow LVADs, that benefit went away. There was no significant benefit. So these authors concluded that continuous flow LVADs, ICDs were not associated with mortality benefit. And this is one of the largest studies that we have. It's an analysis from the Intermax registry, again, 2017. A similar study was done from the UNOS database, which is the organ sharing database in the US here. And so this particular study looked at about 2,200 VAD patients, and they matched in a propensity matching fashion those who had ICD and those who did not have ICD. And what they found was that the presence of an ICD was not associated with any, it actually was associated with a slight increase in mortality and unexpected death among patients with continuous flow VAD. And these people tend to get transplanted more and also had less chances of recovery in that regard. So it's possible that these were slightly sicker patients despite the propensity matching. So I think so this particular study, and again the UNOS database also showed similar results, that the presence of an ICD was not associated with mortality in these cases. So to summarize, if you available data for ICD shows that it's doesn't impact survival, but then again there could be subgroups that benefit, which it's a little bit unclear at this point which subgroup, but it makes sense in people who have a lot of VT for concerns over right heart failure to have some backup, rather than letting them these patients go into right heart failure. So a careful assessment has to be done in continuing ICD therapy in those with pre-existing ICDs. In those who get a VAD before they have a device, whether or not to implant one, it's tricky and has to be done on a case-by-case basis. I would say that a good percentage of them may not need it, and if they didn't need it prior to VAD, but I think those are, we don't have a whole lot of good data on that, and that has to be discussed as a team and, and done on a case-by-case basis. So switching gear to cardiac resynchronization therapy. Again, a good percentage of patients who end up getting an LVAD has a CRT device in place. And the practices has been very variable. Some centers, they shut it off after they shut off the LV lead to conserve battery. Others continue. The hypothesis in terms of, at least from thinking from some of my heart failure transplant colleagues, is that there is a school of thought that thinks that CRT can perhaps improve the resting LV and remodel it in a way that it may allow recovery, meaning that eventual VAD explant. And there is a group of investigators who are very focused on what we call as bridge to recovery. They want to recover the patient from the VAD and eventually explant the VAD. So they think that CRT may be. So that's kind of how we started off doing these studies, basically to look at the outcomes. We published, our group published the first paper in 2015 on small study, 60 patients, looking at outcomes between CRT group and an ICD group. And we noted that adding CRT did not improve survival, hospitalizations, or atrial or ventricular arrhythmias. A similar study from Mayo Clinic published a year later kind of supported our findings. Again, small study. The only thing that they found differently was their study. They thought that if you had CRT on, it actually reduced ICD shocks compared with CRT off. Again, not a control study, had to be taken with a grain of salt. So, and there was no difference in survival. So, but again, these were small single center studies. So we had to expand our, needed more patients, multi-center, get more information. So a recent, there was a randomized study that looked at 41 patients who were randomized to CRT on versus CRT off. And they had an 11-month follow-up. The study was actually not powered enough to detect mortality. They found a trend towards fewer ICD shocks in the CRT on group, but it was not statistically significant. There was no difference in time to first shock, inappropriate shocks, or any hospitalizations or for heart failure or arrhythmias. And overall mortality was the same between the groups. So again, underpowered small study, but there's some signal with regard to less shocks, and that's the rest of it. The survival and outcomes are fairly the same. So we created a multi-center investigative consortium to study the LVAD in arrhythmia and device therapy. So one of the papers is that we looked at CRT and clinical outcomes. We published it in Journal of American Heart Association 2018. Here we looked at 488 LVAD patients, all continuous flow. The majority of them had HeartMate 2, and the rest of them had a heart wear, which is also now, it's actually now called HVAD. It's an intrapericardial VAD. And almost 223 had an ICD compared to the rest of them had a CRT-D. And they underwent LVAD implantation at 5 centers from 2007 to 2015. 478 days were the median follow-up. And median in the BIV group, the median pacing was 96%. So we followed these patients for over about couple of years. About median follow-up was about 478 days. And this is a Kaplan-Meier curve that shows the survival benefit between ICD and CRT groups. As you can see, no significant difference in survival between the two groups over the follow-up period. We also looked at a Cox regression analysis to identify predictors of mortality. And we found that the device type, ICD or CRT, was not significantly associated with adverse outcomes. In fact, the use of amiodarone at baseline was significantly associated with adverse survival. So it's an interesting finding, and we are kind of looking into that a little further right now. And if you look at some of the other parameters, when you look between the CRT group in this column and ICD group here, the heart transplantation, how many underwent was not different. Hospitalizations were not significantly different. Heart failure hospitalizations, were also not different. When you look at arrhythmic outcomes, there was no significant difference between ventricular arrhythmias or atrial arrhythmias between the two groups. And I can see that very high incidence of ventricular arrhythmias and ICD shocks in these cases. The interesting thing that we found that the CRT group, it's assumed that would be the case, had a much higher incidence of generator changes during VAD support compared to those in the ICD group, or 26 versus 15%. And that was statistically significant. And we took into account the time from device implant to VAD also to do this analysis so that it is, we are comparing apples to apples. And so definitely battery drainage is a concern. And doing even something simple as generator changes in these patients can be very concerning, because all VAD patients, they are on warfarin, they need bridging if you stop them, and they also have this acquired 1 millibrand problem, whereby they are more prone to bleeding. So they get and there's an infection concern. Most of these, majority of them, I wouldn't say majority, but a proportion of them have a driveline infection, which has been decreasing, but it's still a concern. And so they have colonization with, so any kind of surgery in these people can be challenging in terms of infection and bleeding. So this, even though it's not a big difference, it's still a concerning thing in terms from a clinical perspective. So to conclude, our large study showed no significant benefit for CRT compared to ICD in this population. No significant difference in arrhythmia incidence was noted. And we also did not note any, and we noted that the CRT group had significantly higher generator changes compared to the ICD group in this case. And then, so there was this question, like, what about people who are sort of CRT eligible? What about people, like, meaning with a wide QRS to begin with at baseline? How do they fare versus somebody with a narrow QRS? So this thought process came because in the older studies from LVAD showed that once the VAD was in, they reported a narrowing of the QRS initially. And it was not, actually there was, reasonable narrowing was reported in small studies, very small studies. So we wanted to see if the narrow QRS people fared better compared to the wide QRS people with bundle branch block. And we also wanted to look at a group of people who were RV paced at baseline for a higher percentage, more than 80%. So the same data set, we looked at about 520 patients, stratified them into those with a narrow QRS, wide QRS, and also with a CRT group. And among the wide QRS group, about 35% of the patients had greater than 80% RV pacing, and about 14% had a left bundle branch block. And we found that during follow-up, there was actually no difference in survival between these three groups, whether you had narrow QRS, whether you had wide QRS, or whether you had CRT. And we looked at Cox regression modeling, and we found that the wide QRS or any changes in QRS post LVAD or RV pacing or CRT, were none of them were associated with survival or hospitalizations in this group. So meaning that the well-studied theory of RV pacing causing dysynchrony and poor outcomes in an advanced heart failure patient may not, be the same in an LVAD patient. Again, more studies need to be done specifically looking at that, but at least the initial signals that, if you have a wider QRS, that doesn't seem to be impacting outcomes in these patients. And this is the, again, the Kaplan-Meier curve showing the difference between narrow, wide, and CRTD. And so in terms of, in this study, wide QRS duration, high percentage of RV pacing, as well as changes in QRS duration were not associated with survival. And then continued CRT was also, as we showed before, we found the same finding in this case as well. And more recently, we also published another paper on basically to strictly compare people whose LV. So out of the 295, 44 patients had CRT turned off post LVAD to a variety of reasons, some just due to choice, some due to lead malfunction, all those things. And what we noted was that turning CRT off again did not impact survival, heart transplantation incidence, or arrhythmia burden, as you can see. So, so in summary, again, available evidence based on one small randomized study and 3 large observational multi-center studies would suggest that continued CRT was not associated with important clinical outcomes such as survival, heart failure, or arrhythmia-related hospitalizations or incidence of atrial and ventricular arrhythmias in the continuous flow VAD population. Again, one has to understand that there may be subgroups that may benefit, and more needs to be done to identify those people in that regard. So switching gears, one last section, what about programming? So we are at a big issue in terms of the current device strategies and how the current devices allow programming and when it comes to the VAD population. So this is the maximum that a current generation ICD allows for detection. Maximum you can get is like a minute, and not more than that, whatever device you look at. And after that, it'll give therapy. So this particular study of 83 patients looked at, they compared an ultra conservative, meaning like the maximum allowed by the device, to the standard programming. And they found that there was no difference in shock incidence or time to shock, even if you extend the detection to the maximum versus you program it sort of out of the box program. But still, the challenge here is that these are people who can tolerate VEF for 2-3 days, but then we need the architecture of the current ICD CRTs are not really amenable to the VAD people because we need longer detection. And so there is some challenges here in terms of how to program this. So our writing group for the scientific session recommended the following, and again, this is just a consensus opinion. A high rate cutoff VF zone, like 250 beats per minute, with the longest programmable detection time available in the device, and use aggressive and multiple runs of ATP. And then you can even program ATP only zones, and then you can do elective cardioversion under sedation. And the programming is unfortunately limited by the current detection limits, and there is actually no good data on CRT programming. Really, we don't know how to program the CRT. So just to go back to one point about mechanistically, why shouldn't CRT work, right? So there are a couple of theories. One is that the mechanical decompression by the VAD, the hemodynamic effect from that perhaps is too good, that any kind of electrical resynchronization may not be able to match it, number one. Number two, there is an anatomical issue. You are taking out a portion of the LV while putting the cannula in, so it perhaps affects the orientation, the fiber orientation, and the conduction, patterns within the ventricle, and the CRT may not be effective. The couple of things that we don't know is that is there a particular subgroup for it works. Number two is that is CRT beneficial for right ventricular function. So those are studies that are underway to look at some of these things. And so overall, those are the electrical synchronization may not be able to match the level of mechanical decompression that may happen from the VADs, probably the likely reason. Medical management, there's not a whole lot of data on medical management. So most of the medical management is using drugs that we use for, standard management in heart failure patients, basically. And anti-arrhythmic therapy use is kind of controversial because especially amiodarone, we have some signals for harm in these patients. And so that's something to look at. And it could be that there is drug interactions. All these patients are on warfarin. It could also be that it's pretty liberally used without much surveillance. That could be possible. Beta blockers are commonly used, but again, there's no data to support that it reduces ventricular arrhythmias. We recently published another paper on looking at digoxin and mortality in these patients and found that digoxin was not associated with any survival benefit. And again, it's a balance of symptoms when hemodynamic consequences versus anti-arrhythmic side effects. The percentage of VAD patients on amiodarone are pretty staggering. Almost like 35 to 40% are somewhere along the line on amiodarone. Either they are before VAD, or they are after VAD in that regard. So not a whole lot of good data on anti-arrhythmic therapy. So again, use anti-arrhythmics judiciously, especially amiodarone. Again, a lot of people are on beta blockers and perhaps some on, ACE inhibitors and stuff like that. And some are on DIG also. The DIG theory comes from improvement in right ventricular function, perhaps. And that, again, available data doesn't support a very beneficial effect in these cases. And so again, so this is a paper that I was talking about. We had a series of patients, about 10 patients who came in with symptoms and signs of acute right heart failure. And they were all found to have KO tricuspid, like atypical atrial flutter with rapid ventricular rate. And flutter ablation in these patients resulted in complete resolution of symptoms and right heart failure, and they felt much better. And so this is a small study and observational, but again goes to show that atrial arrhythmias should not be completely dismissed, and can in some instances can affect right heart function in these patients. Second case, and we'll wrap it up in 5 to 10 minutes here. 56-year-old man with end-stage cardiomyopathy, HeartMate 3 LVAD as destination therapy. He comes with multiple shocks, monomorphic and polymorphic VT, symptoms of, a lot of symptoms actually. Every time he gets VT, he gets dizziness, pre-syncopal, failed amiodarone, multiple drugs, and it's actually reducing VAD. And sometimes, people reduce VAD pump speed to prevent the, at least reduce the suction issues and to avoid, but that didn't help either. So we did EP study on these patients. So I want to quickly go through, or we found 2 ventricular tachycardias, right bundle branch superior axis, 405 milliseconds, and left bundle branch inferior axis, 440. Both are well tolerated. So this was his map. So a couple of things. So this patient had a HeartMate 3 VAD. A couple of things about HeartMate 3. HeartMate 3 is actually considered as a sort of it has a pulsatile component to it. It's really not a classic pulse. What it does is that every 2 seconds, it actually ramps up the RPMs, and then it creates a sort of a pulse in the, and so you can see that change every 2 seconds. The idea is to try to reduce, sludging and thrombosis in the VAD. So, but this particular magnetically levitated components in the VAD actually causes a lot of interference with the mapping system. So this is EnSight. HeartMate 3 doesn't work well with Carto because it actually messes up the motion box. It doesn't work in the EnSight if you use the magnetic stuff of it. It always gives you an error saying that the motion box cannot be found. So in this case, we use the impedance part only to map this. So as you can see, like a huge anterior wall scar pre-existing, and a lot of areas in the posterior wall also, those are so-called a lot of border zone areas. We did a lot of substrate modification. So this is an example of VT in a HeartMate 3 patient. So as you can see, there is a lot of surface noise during. So this is the phase when the non-pulsatile phase for the HeartMate 3. And as you can see that during this area where the pulse happens every 2 seconds, it cleans up, it clears out. And then the low RPM, you still get the noise, and then it clears up with the high RPM. So we don't see this in the HeartMate 2 or LVAD, which operate at a much higher RPM. And you can see here continuous diastolic activity during VT. And you can this noise also happens in the intracardiac electrograms too, especially if they are closer to the VAD cannula. And this is one of the VTs. And this is a location, like the first VT was ablated just on the lateral side of the inflow cannula. So you can see that the inflow cannula in HeartMate 3 is much shorter than the one in HeartMate 2. A lot of hardware in the heart. And this is a RAO view here and an LAO view here, looking at this. So VT ablation is LVAD patients are actually very feasible, and it's actually fairly easy to do. And there are some technical issues that I'll mention briefly. One is that you often encounter extensive scarring, multiple morphologies, but with a combination of targeted ablation and anti-arrhythmic therapy, we can keep these people controlled. A couple of technical issues. One I wanted to look at this. One is you have to be careful about transeptal. If you can't go retrograde, it's very difficult. You have to be careful with that because the aortic valve in these people are mostly closed off. Some people have been sewn shut, so you have to check that, number one. Number two, epicardial ablation is
Gopinath, can you hear us?
Use some kind of imaging to so that to avoid perforation, because sometimes the cavity size can be very small. Number four, the geometry in the standard fluoroscopic views can be a little misleading because the VAD actually makes the LV kind of more rotate a little posteriorly. So you may have to use some caudal cranial views or some to kind of get a better sense of where you are. Typically, entrapment of the ablation catheter in the VAD is typically not a concern. You just have to use a little fluoroscopy to be careful. In VADs like HeartMate 3, which has a shorter distance to the impeller, you had to be a little bit more careful with the catheter manipulation around the cannula. But all said and done, it's actually fairly easy procedure to do. They are supremely stable with the VT. You can even do it with conscious sedation and keep mapping and taking care of these issues basically. And there has to be a technician who can watch the VAD flows during ablation. You need an arterial line because cuff pressures are very unreliable. So you have to do like a mean pressure from the arterial line would be the best way to gauge these people in that regard. So those are some of the technical issues. This is an observational data from about 8 studies that looked at VT ablation of about 101 patients. 60% had ischemic cardiomyopathy, 27% had VT associated with the cannula, but the majority was due to underlying scar. Acute success was achieved in 77 to 85%, but the recurrence there's a lot of recurrence that can happen. But ablation overall reduced VA burden and improved quality of life. And complications can happen. So no deaths, but you can have other things. So it's not so refractory VTs, refractory to medication, ablation is an option. We already talked a little bit about that, and we talked about HeartMate 3 in the noise issue. So this is an example of that surface ECG noise from HeartMate 3. You can see that every 2 seconds it clears up, and this can be mitigated to some extent by adjusting the low pass filter in the mapping system, but it's impossible to completely get rid of. But when you adjust the low pass filter, you also risk not picking up some things in that regard. This is an example of how the arterial waveform during sinus rhythm, and then you induce VT, and then you are in fast VT, and then you can see that the VAD supports it, and you can see that there's a mean pressure. It's a flat line, but it's a mean pressure of about 70. It maintains that. So it's a nice example of hemodynamic support in these cases. So this is a scientific statement that Dr. Vanitha mentioned, and I'm happy to send you a PDF of this for it to be shared with the group. And I'm also happy to share my slides too. So we'll wrap up. In conclusion, ventricular arrhythmias are common in LVAD recipients, are mostly well tolerated, but can result in right heart failure, shocks, and frequent hospitalizations and poor quality of life. Atrial arrhythmias are not associated with increased survival or stroke, but can cause right heart failure. Available observational data show no survival benefit for ICDs, and the same thing for CRT. No survival or arrhythmic benefit so far observed. Subgroups needs to be understood, but and there is increased risk of generator changes, so it may be prudent to turn off the LV lead following LVAD implant in this case to preserve battery. Ultra conservative programming strategy to avoid shocks is recommended. Better detection algorithms to allow delayed therapy are warranted, and it will require working together with industry to change some of the architecture in these cases. LVAD is not a treatment for VT. If you had VT before LVAD, likely that you're going to have it after LVAD. So I think the best strategy is to take care of the VT before they go to get VAD. There are some centers who do intraoperative cryoablation epicardially at the time of VAD implant, or endocardially after they core out the apex in that regard. But that's something only specialized centers are doing right now. Judicious use of antiarrhythmic drugs, balancing symptoms and hemodynamic consequences of VT versus drug toxicity, and not a whole lot of data on this. Catheter ablation of medical refractory ventricular arrhythmias is safe and effective and can reduce VA burden, length of stay, and increase quality of life, because most people are awake when they get shocked. In patients with high burden of pre-VAD VA, concomitant surgical ablation can be considered if you have expertise in that. And a lot of these factors require prospective randomized studies to clearly define the role of ICDs and CRT in these patients. And thank you, and I really appreciate the opportunity to present this. And thank you, IHRS, for having me. I'll hand it back to you, Ullas.
Yes. So, Vanitha, are you there? I was wondering, Bala, can you make some comments and share some experience, and maybe you have some questions for him?
It's a pleasure. It's a wonderful talk. I really enjoyed it very much, especially the succinct way in which you concluded your talk. I mean, those are exactly the conclusions out of we have in our own experience. So, very briefly, we've had 5 major arrhythmias in a series of close to around 45 VAD implants. And I was very interested to see your Cox regression hazard ratio of 1.7 for amiodarone, because the first patient where we had this problem was a patient with a VT storm preoperatively, and we put in an HVAD into him. And we came down on the cordron to around 200 milligram twice a day. And he was on that for a few months. And then we tried to taper off the cordron. And twice he came back with feeling unwell. He was not dying, he was not sick. His VAD flows had come down from 4.5 liters to around 2.5. And each time we connected a monitor, he was in VT and VF. So as you said, they are alive, but the RV is not pumping. It's like a Fontaine circulation. If your pulmonary pressure is high or a PVR is high, you're sicker than if you're otherwise. So we had to leave him on he was not in favor of an ablation. In any case, we were worried that if you take a catheter inside a ventricle with a functioning VAD, whether it's tucked in or there could be consequences. So this patient came back after 1 year with epididymitis. Now in this country, in India, if you get swelling of the epididymis, we think it's filarial because of a mosquito bite. I did not know that epididymitis is a surrogate for cortisone toxicity. There are 20 case reports in the world of cortisone toxicity, which is unexplained as to why epididymal swelling has to happen. Then he developed full-blown liver and lung toxicity with very high levels of 2,3-deoxy amiodarone, which is the metabolite which is active. And we had to use a polymyxin B filter to reduce the levels. And eventually, after several months, he died of cortisone toxicity. So the finding that you have an odds ratio which is significant amongst all other factors perhaps could be explained by that. So two other things is our current practice is when you have a patient with chronic atrial fibrillation, and unfortunately, you see patients with that, we make a point of amputating the left atrial appendage apart from anything else, because the risk of stroke is the biggest risk, as you mentioned, in VAD. So that is one thing. And in 3 patients, we had to transplant them because the shocks were happening in the daytime and it was painful and it was really leading to a serious drop in the quality of life. So is it your current practice to ablate, because you have a big hole in the ventricular apex when you're implanting the VAD? So through that, you could actually access any area of the ventricle. Is that your current practice?
So, right we are in our institution, we are not doing that. I think it's partly due to, surgical protocols and so on and so forth. I have been, involved in a couple of these cases. It's a little bit of a logistical challenge to get through some of these things because the mapping can be very tricky intraoperatively once you have the sternal retractors and all that in the, there's a lot of, interference happens and the map kind of goes, you can manually map using a handheld catheter. So you kind of have to go by what you mapped in the before and kind of identify the areas for the surgeon to do cryoablation, endo, and epicardially. I still believe that if it has good value. I think the initial observational data are salutary, and I think people who thought process would be that if somebody is being considered for VAD and they are relatively stable to undergo VT ablation, we should do that ahead of time. And if they're too sick, can't go, then I think consider endocardial and perhaps epicardial cryoablation based on prior mapping and any kind of imaging that looks at wall motion, and you typically target the border zones or the hinge point between scar and normal tissue, and I think it can make a difference in terms of the immediate post-operative period where these VTs may happen more frequently because of catecholamine issues, as well as down the road, as you mentioned, with regard to recurrent shocks and quality of life issues. To also comment on your amiodarone question, actually we are collecting data right now on specific toxicities that we have encountered. We do not know what exactly is the underlying cause. But I also, at least in the US, I've seen very liberal use of it. Sometimes they are on it and nobody knows why they are on it, and without any clear indications. And we see that. So there is some surveillance concerns. There's some probably drug interaction issues, especially with digoxin and warfarin. And then, they have so many other things going on that, like the interesting example that you mentioned about epididymitis, and those kind of things are probably missed. That's probably, and so we may have more to share in the next few months.
Right. So Bala, if you think you have done with your comments, let me go through some of those questions and comments by the attendees here. I have some 3 questions and 2 comments. Rakesh, can I read some questions for you on their behalf?
Absolutely. Yeah, absolutely.
So Ashish Nabar has 2 questions for you. One of the questions is, what's your experience with respect to biventricular assist devices? And especially in dealing with the right ventricular, failure.
Yeah. I would probably defer to Dr. Bala to answer that. I don't have much experience with biventricular devices. We rarely have had one, and I mean typically it's a so in terms of arrhythmias there, I can't comment because the numbers are too small. And perhaps Dr. Bala, what do you think?
Yes, biventricular assist devices in general don't have an outcome which is comparable to the left ventricular assist device. They're distinctly inferior. There are now limited number of case studies looking at putting 2 HeartMate 3s, one in the atrium on the right side and one on the left side. But increasingly now, we are much more liberal in using a LVAD perioperatively. In some series, it's as high as 40%, and then remove it after 2 or 3 days. And as you said, right ventricular failure continues to be one of the commonest causes of mortality, along with sepsis and VADs. So the other option that people looked at was a total artificial heart using syncardia, but that's a clunky device. So at this point in time, right ventricular dysfunction or severe RV dysfunction, you would perhaps be better off with the transplant than looking at BioVAD.
Right. So now there's another question from Ashish. It's something to do with the anticoagulation. What is the NOAC record with anticoagulation with LVAD patients?
You cannot use NOACs, at least they're not recommended. So all patients get warfarin. So NOACs are off limits, at least so far. And I'm not aware of any study on that because of the mechanical device.
It appears that, they are not to be used. Dr. Anup Gupta has a question for you. And that is, for example, a sick case of left ventricular dysfunction, wide QRS, LBBB, when you actually advise LVAD over CRT?
So this is an interesting question. I think there has been some, what I call it like indication overlap between, or at least going to be some indication overlap between that kind of, so the issue is like, what do you do with this sort of ambulatory class 4 patients and who have this feature? So would you, there is, so it's a kind of like from a CRT standpoint, we want to offer it to more sicker patients. From a LVAD standpoint, I think the MCS, like mechanical circulatory team, they probably they're looking at more offering it to more lesser sicker people in that regard. So I don't know the exact answer to that, but I think obviously, VAD is, at least from our perspective, is a more involved procedure, and I think CRT can be done without much of a complications. So I think in this particular patient, I would try CRT, but at the same time involve the heart failure mechanical circulatory team so that they are also involved, so that if it doesn't work out for the patient, they can move towards mechanical support. So I think, so the one thing I want to emphasize here, like what we have mentioned in our scientific statement also, I think these are not, siloed approaches are not going to, we have to, it has to be a multidisciplinary effort. Will involve people, everybody involved together, talk about what's the appropriate thing. I think that's the best case scenario. In this particular case, I probably do CRT, but at the same time, I would engage, Dr. Bala's team in this case is say, hey, we have this patient who's not doing well, we're going to do this, but at the same time, we want you to be involved. In case this doesn't work, you go forward with the next step in that case.
Going along with Anup's thought process, Suchit Mujumdar is now thinking really very, very ahead. he thinks about physiological pacing. Those people who are for conventional CRT, maybe a physiological pacing would make their candidature for LVAD, postponed, maybe.
It's again, that's a question that needs to be answered. Initially, we have had reasonable success in correcting left bundle. I mean, Ulla, as you know more than anybody, you've been an expert in this field, and reasonable success in correcting left bundle, but the right bundle people still remain a problem, and you end up seeing a lot of sort of these odd-looking IVCDs after LVAD, and so it probably speaks to the underlying substrate that these people have, and so I think that could be one challenge that we have to resolve. Maybe physiologic pacing is better than this, but I think the overall, my thought process, again, this could change with new data, is that the electrical synchronization, how much it can benefit is yet to be proven, whether it's CRT versus, his bundle or, bundle pacing. But, and we really don't know if white QRS is actually detrimental in these patients. It may or may not be. Because the whole physiology is completely different when you're coming to a situation where you are massively decompressing the LV, and you have really no wall stress in that cases. And so those are how does it tack against electrical synchronization is something that we need to understand better.
Right. So now Ajay Naik makes a comment and a question. First, his comment. Ajay says that the issue of sepsis, they are involved. Sepsis issues, they are involved. The issue of right ventricular heart failure in cases of LVAD, these issues are so very much important as compared to whether the patient was having a wide QRS, whether the patient had RV apical pacing, he had a CRT or ICD. He thinks those are the issues which probably do not determine the survival post LVAD. How do you manage the sepsis, maybe anticoagulation? These are the issues what he thinks are pretty important.
No, I completely agree. I think the arrhythmic death is not a huge factor in these people. I think obviously, like we say, the lead is the weakest portion of a device. In their case, the driveline is the weakest portion, basically, and so that's what the infection issues come from. A lot of people are chronically colonized. They're on continuous suppressive antibiotics. Right heart failure is very, very much of a concern for people, heart failure docs who care for these patients. So hence the added, very, very concern about the persistent atrial or ventricular arrhythmias in these people, and how can we preserve the RV? That is a big thing. So I think as EP docs, I think our goal should be to assist in these cases to prevent, to understand that the priorities here are a little different. We are trying to improve quality of life, trying to improve right heart failure, rather than shooting for mortality and those kind of things. I think we have a very important role to play. I think that I understood over my years of working on this is that there is wide variability in practices, and I think and we have improved that a lot by creating some data around it. I think we need to continue to work to identify collaborative efforts in this too, like intraoperative VT ablation that was mentioned, and those are things can be done to reduce VT burden and improve quality of life.
Yeah. All right. So now you had highlighted about the difficulties that could be encountered, the challenges with respect to invasive way of doing catheter ablation, say, for example, ventricular tachycardia. Now, Ajay Naik wonders, now that we know there is something called non-invasive VT ablation or a radio ablation, has that been utilized in LVAD cases? That is his question.
Not that I'm aware. I would suspect that it would be a challenge because of the, in order to get to the LV, the VAD should be in your way. And, like whenever people want to do chest radiation, we want to obstruct the path or, I'm not aware of any reports on that, but my suspicion is that it will be technically very challenging to do that. In that case.
Yeah, but then I think we all
given the hardware that is.
Yes, but I think we will be better when there are technical challenges. So I think
I think that needs to be studied.
One day, definitely a non-invasive way of ablating these arrhythmias, especially with such kind of devices inside, should be the norm or the routine. Ramdev, the other way, is asking you a question, whether the in situ device, either an ICD or CRTD, are there any more instances of inappropriate shocks because of their functionality?
Not that I'm aware, actually. They actually function pretty well. There is the mechanical. There are hardly any interference issues. There could be some changes in lead parameters after the VAD implant. Sometimes you may see some slight decrease in sensing and impedance rises and so on and so forth. But overt lead failure or significant noise from the VAD itself is very, very uncommon. And I think they function pretty well.
Right. I think Paul Chaco had made a very, very relevant remark with the thought process of Dr. Ajay Naik, which you also hinted, because there are so many metallic components involved in LVAD. Paul Chaco thinks, first of all, a non-invasive VT ablation itself needs to be validated. On top of that, these are the devices, the LVADs, which are using magnetic components to levitate and things like that. So presently, I think it's a huge challenge. So non-invasive or a radio ablation, Paul Chaco thinks, I think it's not in the near future. Maybe later. I think Paul Chaco's comment is quite relevant here. Suchit Mujumdar asks you a question. Can, for example, genetic analysis or in general, the risk profile of that patient would help you in determining whether this patient should go in for an LVAD or a CRT or maybe straight a transplant? Is there any kind of a risk stratification? Who benefits most with what? Is there a chart like that?
Oh, that's I hope we get there someday. That's I can say. It's a very important question, but I don't. It's very personalized therapy situation. I think where can we intervene? I honestly don't have a clear answer to that in terms of. There are some disease processes that we know that they progress, like ARVD and so that the lamin mutations and non-compaction.
And Rakesh, for your information, Suchit always thinks very, very ahead of time. He could only ask a question but I think that is where we should be reaching soon. We got to be figuring it out who deserves the therapy the best. And
I completely agree, and I think
I think Suchit's thinking is quite correct, and I hope
I think the non-ischemic cardiomyopathy spectrum requires more study. It's all what we club into that category is there are several disease processes, and we need to better understand how it happens and what are the underpinnings of that too. So that's
Yeah, so Paul Chaco has a question, but before that, Ramdev Yadave asked you about some surgical details here. And one of them is something to do with the torsion of the outflow cannula. Are there any issues, you are coming across? He thinks that is being reported often these days.
That I'm not sure. I haven't come across any issues. I don't know. Maybe Dr. Bala, you may know, but outflow cannula.
3 or 4 instances of torsion of the outflow cannula. Now that's been fixed because they've introduced another new ring around the exit site from the pump, which prevents torsion. So that problem is solved. But I see another question here regarding RV dysfunction. In Momentum 3 trial, RV dysfunction is a major cause of mortality. what's the cause of RV dysfunction? Now, that's a postgraduate question. I mean, that requires a lecture of 1 hour to, there are various causes. One is, of course, a lot of cardiomyopathies are biventricular diseases. So the right ventricle is as well is affected as well. Number two is a lot of RV dysfunction is also related to volume overload. So if you get a very edematous patient whose creatinine is high, who's waterlogged, and you're not able to get rid of the water, typically these are patients who are referred late. Right ventricle can struggle. Third thing is any kind of bleeding is poorly tolerated. If you have multiple blood transfusions, the RV tends to struggle post-surgery. Or if it's a redo, almost 40% of VAD implants these days are on patients who have had multiple previous operations or ventricular aneurysm resection. So in the process of getting to that side, if you injure the RV in any way, it gets worse. So increasingly now what we tend to do is that lateral thoracotomy, a lot of VADs are now getting implanted through a small incision in the left chest. So there is some evidence that what is called a lateral approach, where if you don't touch the RV and the pericardial restraint over the right ventricle is maintained, the incidence of post-operative right ventricular failure is less.
All right, so those are the issues why the RV dysfunction can take place. Now, Paul Chacko has a question for you, Rakesh. That is something to do with the VT circuits. He is asking you, do you have some data, the incision site for the LVAD in the LV apex or wherever, those incision sites, have they been a problem for post-LVAD VT circuits?
Yes, typically once we place a VAD, we don't ablate until like a couple of months before the site to heal. Number two, in the observational series of like about 8 studies, there were about 27% of the patients that were involved in those out of the 110 or so had reported to have the circuit or the exit site near the cannula. Does it mean that it goes around the cannula? Hard to say, but I think they had, it's probably the substrate around the suture line essentially. So yes, I've had 2 or 3 instances where that was the case, and they're pretty easy to take care of actually. So overall, it's lower, but it's I would say one fourth of the time you may see that.
Right, great. So I think we have time now for one last question from Ramdev Yadave here. He is asking you if you do the ablations, maybe small or large, especially in the LV side, does it also add to the increased risk of stroke?
So we haven't seen any. Again, out of about 110 ablations, they reported a CVA. The stroke risk was about 2%, so we don't stop their anticoagulation, keep them at whatever INR they are, and we heparinize as soon as groin sheets are in, and keep them at a high ACT level, close to 350 to 400, and most of the VAD VT kits that I've done, we do it with conscious sedation so that we can monitor them closely for any changes in neurological status or anything like that. We tend to do echo with contrast, and just to make sure there are we're not dealing with any LV thrombus to begin with, which is very unusual in LVAD patients. Almost always, transeptal 100% of the time. We haven't had any issue. So far, I haven't had any stroke-related problems. The procedure itself is actually not that difficult to do, but the issue is success rates. They have so much substrate that you end up, you ablate one, they may have another one. So it just, it can be there all day if you want to, but I think the idea is to, for more targeted ablation, minimize the time you're in there and for the most benefit of the patient.
Great. Thank you so very much, Rakesh. And we learned a lot, even though it's not really a very familiar field for us. You threw really great light on these issues. And Bala, as usual, your comments were so extremely important. You were the right person today so that we could communicate better with Rakesh. Rakesh, from my side, I'm thankful to you. I learned so much. Bala, thanks from my side to you too. And Vanita, over to you.
Thank you so much, Dr. Ullas. And I would say, yes, it has been a very interesting session away from the EGMs and device shock therapies that we have been dealing with. It's a very different field, Dr. Bala. I'm really thankful from the bottom of my heart that you could make it today. And we really enjoyed it. And thank you, Dr. Rakesh. It was beautiful, very nice presentation, very different thing. And you are, as I told you in the beginning, that you are the first international member of IHRS to have made a presentation today in this web series. And I really love it. I mean, at Ullas, we enjoyed it, right?
Absolutely. Absolutely. It's an honor to have him. He's an authority. As I said, he is the first author of American Heart Association statement addressing this issue.